Hello, my name is Sarah Ferranti, and this is my change and quality management presentation, according to a PDSA model, on reducing catheter-associated urinary tract infections. As part of the planning part of this presentation, I had to identify the issue at hand, and I've identified urinary tract infections as one of the most common infections in the acute care setting. It compromises about 40% of infections in the hospital, and approximately 80% of those are associated with catheters. There have been approximately 560,000 cases reported annually for UTIs and 13,000 associated deaths. The National Patient Safety Goal number 7 is to reduce the risk of healthcare-associated infections, and this includes CAUTIs. The Joint Commission uses this as a part of their assessment for standards of care when they are evaluating hospitals for accreditation. As of October 2008, the Center for Medicare and Medicaid Services does not reimburse for services related to CAUTIs. For quality variance, the performance standard goal in 2009, the Center for Disease Control recommended a reduction in incidence of CAUTIs by 25% by 2020. Compliance with the MPSGs for CAUTIs is required by the Joint Commission and state agencies for both accreditation and licensing. And this, of course, includes the indication and early removal of catheters. Supporting evidence, since this recommendation was put in place, there has been no change in the rate of CAUTIs. And the incidence of CAUTIs is directly related to catheter use, and the risk of UTIs increases approximately 5% with each day a catheter is in place, according to the World Health Organization. Our root cause analysis, I spoke with some team members from quality management and infection control, and both of them were pretty much in agreement about what is the cause of CAUTIs in our facility. And it's actually pretty much nationally, according to some research that I found. And those include improper use of sterile technique, improper catheter care, improper placement of the urinary drainage bag, that there'll be dependent loops, which can cause backflow, which can increase your chance for UTI, improper assessment and reassessment of the indwelling catheter, improper or inappropriate or unjustified use of the catheter, prolonged use of a catheter, and lack of training and education in catheter protocols. The scope. The solution, it's pretty simple. We need to implement guidelines to reduce the number of UTIs linked to catheters. The improvement goal that I set with the quality management was to decrease the number of CAUTIs in the acute care setting by 10% in 1 year. The stakeholders involved include the patients, the doctors, the nurses, nurse managers, infection control team, quality management team, the Joint Commission, and licensing and accreditation agencies. The plan, the solution, how are we going to accomplish this? We're going to ensure implementation of MPSG recommendations for preventions of CAUTIs, including education and training staff for insertion and maintenance, educating patients and families regarding catheter care, developing written policy regarding catheter indication and use, monitoring the catheter frequently throughout your shift, ongoing assessment of catheter use and indication. At our facility, the current policy includes a number of other things, such as a urine sample prior to insertion, daily assessment of Foley justification in the MAR or in the EMR, a MD daily acknowledgement of Foley justification. This is a recent thing we just put into practice maybe about 5 months ago, that the MD that ordered the Foley has to go in each day and acknowledge that he thinks that the Foley is still indicated. And the nurse also has to check off on that. And finally, we have prompt removal of catheter if it's no longer indicated. Implementation. This is the do part of our plan. Within the first month, quality management and infection control need to evaluate existing policies regarding placement and maintenance of indwelling catheters. Within the first 3 months, the nurse managers need to ensure proper training and education for the staff with an annual competency checkoff. At our facility, we're going to do this twice a year. Step 3, which is ongoing, the doctor will assess the need for indwelling catheter for each patient in accordance with the policy. Step 4, the nurses, another ongoing one, the nurses will also evaluate if the indwelling catheter is in accordance with the policy. Step 5, the nurse will educate the patient and the family on indication for the Foley and on daily maintenance. Step 6, ongoing, the nurse will obtain a urine sample prior to insertion. Step 7, the nurse will use sterile technique upon insertion with appropriate documentation. To just have a little caveat to that, at our facility, we always have 2 nurses doing when there's going to be an insertion of a catheter to ensure that the sterile field is kept sterile, and both nurses will sign off in the medical record as that this was done with sterile technique. That's been something also that's been new within the last 5 or 6 months. Step 8, the nurse will assess the need for the Foley with each shift and prompt removal in accordance with the policy and will document appropriately. Step 9, ongoing, the doctor must sign the daily justification note in the MAR each day, in the EMR each day. Step 10, the nurse will ensure catheter placement, catheter care, and urinary bag placement and care at least once per shift, but really throughout the shift. And finally, within 1 year, the Joint Commission and other agencies will review CAUTIs as part of their annual accreditation and licensing evaluation to make sure that we're keeping up and that we are seeing a reduction. Our analysis is going to include a lot of data collection. We're going to assess all the results of the urine samples and cultures that we get. We're going to look at what did it look like before and what did it look like after, and really just how many CAUTIs do we actually have, and are we seeing a reduction? We're going to evaluate the existing policies and protocols for the catheter use. We're going to evaluate the documentation, all the documentation on the use, the assessment, the care, and the justification. We're going to make sure that the competencies are signed for all the staff that are associated with the catheters. Infection control, we're going to look at their reports on the CAUTIs. We're going to, again, see, are we seeing a decline in the number of CAUTIs we're having? And finally, quality management will make sure that their research is current and that they are updating the policies as needed. Our next steps, our acts. What we need to do is we really need to be offering alternatives to catheters when we can. If it's not indicated according to the guidelines set by the policy, we need not to use them. It can't be for the convenience of the nurse or the patient. I have patients asking to put in a Foley, and we're not going to be doing that. We're going to offer condom catheters, urinals, bedpans, and we're going to do frequent toileting and changing. Management is going to ensure that there's 100% participation in the trainings for the staff. They're going to look at the competencies, they're going to make sure staff signs the competencies, and they're going to set up these mandatory trainings. Infection control and quality management teams, they're going to update the policies based on current research. And finally, the nurses, we're going to educate the patients and the families. We're going to tell them about the catheters, but we're also going to tell them they need to question the doctors and the nurses if they don't think that the catheter is appropriate. At our hospital, after talking to quality management and infection control, they decided, yeah, we need to put in more information out there. We need to be paying more attention to this. Because our numbers really haven't been changing over the last few years, and we do want to see a significant reduction in the number of CAUTIs. So they put this up in our room. I took this picture at work the other day. And I just noticed that it was brand new. And I was like, oh, I wonder if this had anything to do with our discussion. And it's a great little chart. I encourage you to read it online or just take a snapshot of it right now. It's a great way. Our number one goal should be preventing UTIs and CAUTIs in the hospital setting, and hopefully we will see a reduction within 1 year. This is my list of references. I thank you very much for listening.